Srikant, the YouTube live has started. Yeah, I see that YouTube live has started. Good, good. Yeah. So, sir, I will be sharing your link also, the YouTube live link. So, anytime you'd like to share that things, you can share to your colleagues
Yes,
also.
we are live, Dada. We are on
Yeah,
YouTube.
live. Yeah, yeah. Right. No. Okay. Okay. So 2 minutes to go. With the 2 minutes, after 2 minutes, we'll be starting the session. Sir, this is the IBS awareness month, as you know, sir.
Yeah.
So it's our privilege to get you a speaker on that month regarding on the IBS.
Thank you. Privilege is mine too.
Yeah, right, sir. Because in the IBS awareness is very poor. Among the patient is very, very poor.
Agree.
Yeah. Right. We just wait for the 1 minute. 1 minute to go. Yeah. Then I can give you your introduction. Then you can start the session. Yes. Just wait. Okay. Almost. Almost 17 participants, but we expect more. At least 30, 35 we expect. Or 50, sometimes it will go to the 50. Sandeep?
Yes, sir.
Sandeep, you gave a last time reminder to the other doctors to join.
Yes, it's given, sir. Given.
Yeah, yeah.
Yes.
Srikant, could you make me host again?
Yeah, you are the host now.
Yeah, thank you. So we start our IBS group, right? I just give sir your introductions. Good evening, doctor. I, Chayan Majumdar, on behalf of Zydus, welcome you in IBS Gurukul. As you know, doctor, IBS is increasing rapidly in India. So in this IBS Awareness Month, we have organized an IBS Gurukul. It's our pleasure to have Dr. Avval Sadikot as a speaker of today's IBS Gurukul. Today's topic is IBS diagnosis and management. Dr. Avval Sadikot stood first in All India DNB exam in the field of gastroenterology and hepatology and was awarded a gold medal. He was the second in the Torrance Young Scholar Award in the field of medical gastroenterology and hepatology. He is also an expert in GI mortality, has performed more than 500 manometry. He has performed more than 10,000 upper GI endoscopies, 4,000 colonoscopy, and 1,000 ERCPs. We believe this IBS Gurukul will be useful in your day-to-day practice. During the IBS Gurukul, you can post your question in the chat box. Now I request Dr. Avval Sadikot to start today's IBS Gurukul. Over to you, sir.
Thank you, Mr. Chayan, and thank you, Zydus, for this initiative. So IBS, we as a gastroenterologist, we see IBS, number of patients of IBS day-to-day OPD practice. I believe they still form the major chunk. Actually, the major chunk is being formed by the functional GI disorders, and IBS is again a major part of those functional GI disorders. So, but having said that, it is still, I think, one of the most neglected disease or syndrome by most of the gastroenterologists. On a lighter side, we always, from our experience, we said that the more the number of files the patient is having, the higher the chances that he is suffering from IBS. So, for example, say if there are 10 or 20 gastroenterologists in the town, and if the patient enters your OPD room with 5 or 6 or 8 files of different gastroenterologists, we usually make a spot diagnosis that this patient is suffering from irritable bowel syndrome. So, and the moment most of us make that diagnosis, you must agree that we start taking that patient less seriously. Most of the times we, even being a treating physician, being a super specialist, we also feel that, okay, this patient might be having IBS. Let me not, pay more attention or pay more energy to this patient. But the flip side is the patient has already visited 5 or 7 or 8 gastroenterologists in your city, and still he is willing to come to you for his treatment. That shows how much he is suffering. I would give you example of the magnitude of the problem. One or two studies conducted in USA and Britain. In one questionnaire, the IBS patients were asked, okay, if we give you a medicine or we, make a barter system, like we treat you and relieve you of your symptoms. But because of the treatment, maybe you will have 10 years less of life. So are you willing to undergo that treatment? So majority of the patients said that yes, even if you are giving 10 years less of life, but that life is without the symptoms of IBS, we are ready to undergo that treatment. In another questionnaire, patients were asked that we are giving you one tablet for symptomatic relief for relief of IBS, your condition, but there is 1% chance that you might have adverse reaction, and that adverse reaction might be life-threatening. So 1 in 100 may die because of this treatment. Are you still willing to continue with their treatment? And majority of them replied that yes, even if there is 1% chance of death, but if there are 99% chances that we are relieved of all our symptoms of IBS, we are ready to undergo the treatment. So that just shows how much they are suffering from the IBS. Why we don't pay much attention, or why we don't take it seriously, is maybe because the pathophysiology is not completely understood. The guidelines are not there. Guidelines are there, but they are not, that good that we can give 100% satisfaction to the patients. So kind of there is no single pill which can, fit all the bill. It has to be an individualized approach, and the combination, mix and match of the drugs vary from patients to patients. It is always more time consuming to treat such patients, and even after spending considerable amount of time, even after repeated follow-up visits, chances are high that the patient may not be fully satisfied with your treatment. So let us try to look into the problem and try to find the solution. I believe all of you are also gastroenterologists and practicing gastroenterologists. So let us make this an interactive session rather than one-way communication, because I am sure as far as treatment management of IBS is concerned, individual experience also matters much more than whatever the few little guidelines we have. Because ultimately, as I said, there is no uniform formula. It is always mix and match, and individualized approach is always helpful. So I request all of you to share your experience at any point of time. Let us begin the presentation. So IBS, irritable bowel syndrome. So we'll be discussing some introduction and prevalence first, and then diagnosing criteria. Lastly, the management of IBS throughout this talk. So in general, IBS is defined as abdominal pain with altered bowel habits in the absence of any other mechanical, inflammatory, or biochemical explanation for these symptoms. So symptoms are there, patient is suffering, but we don't have any explanation. There is no findable cause which we can attribute to all these symptoms. There are many theories. Many patients show some alteration in some of the internal milieu, but again, there is no uniform explanation for all the symptoms for the entire IBS. So in general, IBS, most of the doctors do agree that this is what they identify IBS as. Prevalence, though there are very few prevalence studies in India, but abroad studies, they do say that almost 1 in 10 in general population is suffering from IBS. Reported prevalence, the range is very wide, from 10% to even 30%, 10% to 20%, and out of these, only 30% of them seek medical care. So majority of them, they don't seek medical care, but they keep on suffering silently. At 5 years follow-up of IBS patients who are seeking medical care, only 5% report complete resolution of symptoms, and 30% report partial recovery. So most of them, even after 5 years of follow-up with a super specialist, are having partial recovery only. America, it is seen in more in females. In Indian subcontinent, it is more in males. but I do believe that that is because in India, chances are high that males report to the doctors earlier than females. Most of the times, because of the skewed sex ratio and because of male predominant society, females are, usually prevented from going to a super specialist for such minor or such minor symptoms, which are obviously not life-threatening or which are obviously not very seriously looking symptoms. So that's why it is reported more in males rather than females. That is what I believe. The prevalence of IBS in India is estimated between 4 to 8% and continues to be on the rise. Again, I feel this is an understatement. Whatever prevalence has been shown in the study is less than what we see in our day-to-day OPD practice. But because, it is very difficult to conduct a study in the field of IBS because of lack of proper diagnostic lab modality or any diagnostic parameter. We only depend on those criteria, and based on criteria, again, it is very difficult to fit all the patients who are, probable IBS to confirm IBS cases. We'll discuss as we go on in the lecture further, but this is what some of the studies they do show. So ROM4 criteria letters for the diagnosis of irritable bowel syndrome. So for adults, recurrent abdominal pain with onset at least 6 months prior to diagnosis, associated with 2 or more of the following. Why 6 months? Just to make sure that whatever we are dealing with is IBS only. IBS, as we all know, is a relatively benign condition. It is not a life-threatening disease. And usually it is non-progressive in terms of organic signs and symptoms or lab abnormalities. So that is why a period of 6 months is kept in the criteria. So if there is anything which is organic, which may be life-threatening, usually it shows progression over the 6 month period. But if it doesn't show any progression, lab parameters are still all right, overall patient's physical condition is still okay over last 6 months, in spite of having the symptoms, it is highly likely that we are dealing with IBS. So 6 months is the duration with 2 or more of the following, at least 1 day per week in the last 3 months. Related to symptoms are related to defecation, associated with a change in frequency of stool, and associated with a change in frequency, or that is appearance of stool. So what is different from ROM3 criteria here? So there are 3 major differences. ROM3 criteria, they also included discomfort. Now discomfort is a relatively subjective term, and it is being removed from ROM4 criteria to make them more specific. In ROM3 criteria, the symptom here, it is 1 day per week. In ROM3 criteria, it was at least three days per month. So again, they have made it more specific, 1 day per week rather than 3 days per month. And third one, the pain was associated rather than associated. It was relieved with passage of stool, which is removed from this. So it may be relieved with passage of stool, or it may get aggravated after passage of stool. So they have included the vague term associated with change in frequency and associated with change in form rather than relieved with passage of stool. But what is why the criteria have been made more specific? So overall, if you see the prevalence studies, and if you apply ROM3 criteria, the prevalence of IBS was around 11% according to 10 to 11% according to ROM3 criteria. But in the same prevalence study, if we, for the same patients, number of patients, if we apply ROM4 criteria, the prevalence comes down from 10 to 11% to around 4 to 5%. So, it is maybe on a lighter side, if we are not able to, actually relieve the symptoms, let us reduce the number of patients by redefining criteria. But actually, why it was done? Because in our country, in this part of the world, overall disease burden and all those things, they are not very much, very much looked into. But for foreigners, for Western populations, the disease burden and all, they matter a lot for making our policies also. So by doing this, they actually, made so many patients from IBS bracket to probable IBS bracket. They shifted them to probable IBS bracket. And in a way, they made sure that actual patients who fit into IBS, who need specialized care, are more specific patients rather than diffuse vague patients. For children also, there are ROM4 criteria for IBS. Abdominal pain at least 4 days per month for at least 2 months before diagnosis. with one or more of the following, which is same related to defecation associated with a change in frequency of stool and associated with a change in form of stool. So basically, ROM4 criteria are there to diagnose IBS, but for our day-to-day clinical practice, I'm sure most of us are not following ROM4 criteria. There are more for study purpose, for uniformity of inclusion or exclusion of the patient in any clinical trials. But for day-to-day practice, most of us, we do not wait for the patient to have this 6 months duration. Also, we do not specifically ask whether the symptoms are 1 day per week for last 3 months. Most of us, with our clinical experience, we do make sure that there are no alarming symptoms. Patient is not having any major organic cause, and the duration of the symptom is long enough to rule out other major organic causes. So this is mainly for research purpose, for trial purpose. In our day-to-day OPD, most of us do not follow this criteria. It is very important to subclassify a patient with IBS because, as I already said, that there is no uniform therapy for all the IBS patients across the spectrum. So the chances of being successful in treating this patient are very high if we subclassify the patient. Why? Some of the drugs which which help the IBS-C patients, they actually worsen the symptoms of IBS-D patients and vice versa. So, and some of the drugs which are, mainly they act mainly on the pain part, they are more useful for IBS-U patients rather than the drugs which change or alter the stool form or stool frequency. So if you don't subclassify the IBS patients, chances are high that you may not be successful in treating the patient. So how it is subclassified? We all are having Bristol stool chart in our OPD practice. According to that, if the patient is having type 1 and 2 stool for more than 25% of the times, it is classified as IBS-C. If patient is having type 6 and 7 stool for more than 25% of the times, it is classified as IBS-D. If both 1 and 6 are there for more than 25% of the times, it is IBS-M. And if patient is fulfilling the ROM criteria for IBS, but he is not having more than 25% of the times any specific type of stool, so that is IBS-U. Most of the times we see patients of IBS-D and IBS-C followed by IBS-M and least percentage of IBS-U patients. So let us discuss pathophysiology shortly. As I already said, the pathophysiology is not completely understood, but there are various theories which attribute some of the symptoms of IBS to some of the pathophysiologies. Out of that, dysbiosis, most of us do believe in dysbiosis. Also, intestinal permeability, increased intestinal permeability, mucosal immune activation, visceral hypersensitivity, altered brain-gut interaction. These are the factors we usually see in day-to-day life again as a part of IBS pathophysiology. Let us discuss some of the important factors. So basically, IBS is a biopsychosocial disorder. It is something which requires ideally a multi-speciality approach rather than only a gastroenterologist being there. It requires also a motility physician. It may require a gastroenterologist. It requires a psychiatrist or psychotherapist. So multidisciplinary approach, or one person who knows a bit of everything, should be able to successfully treat IBS patients. So there is abnormal GI motility, there is visceral hypersensitivity. Also, CNS modulation of pain plays a role in IBS symptoms. Role of stress and psychological factors is very well known. Role of immune or inflammatory mediators and role of serotonin in GI function in IBS. So visceral hypersensitivity. We all know that IBS patient usually their pain threshold is less. They tend to identify or they tend to report abdominal pain even at the slightest provocation. So recurring abdominal pain, even tenderness in left iliac fossa, pelvic region, that is below umbilical, lower abdominal part, is also there on physical examination. If for some reason we do colonoscopy or sigmoidoscopy, we all know that these patients are very poor, they have got very poor tolerance for sigmoidoscopy or colonoscopy. Even with slightest distension of the colon with air, they start screaming that they are having severe pain. The same thing I have experienced while doing manometry of these patients. Whenever there is balloon inflation, this patient experienced more pain. Even their first sensation and overall first sensation while inflating the balloon is at a lower threshold, and they tend to tolerate overall less size of balloon than the normal population during manometry. They also have heightened perception of physiologic intestinal contraction. So, for an individual who is not suffering from IBS, what they perceive as a normal intestinal contraction, or they do not perceive them at all. IBS patient come and complain in the OPD that they do feel that there is something moving inside, that some liquid or some gas is traveling from one point to another, which is associated with pain. They also can feel that while passing the stool, something is moving inside. So they have heightened perception of physiologic intestinal contraction. An explanation is that the sensitivity of receptor in the viscous is altered. Now, which are these receptors? So if a normal person, when that person is having abnormal distension, ischemia, or an infection, when in this disease condition, silent nociceptors are recruited in a normal person, but in a patient with IBS, even in absence of this abnormal condition or disease condition, these silent nociceptors are active and they are hypersensitive. So even with normal distension, normal movement of intestine, these silent nociceptors, they do send signal to the brain that something abnormal is going inside. And that's why these patients, they have abnormal pain sensation, even with normal GI findings. CNS modulation also plays a major role. They have a dysregulation of what we know as brain-gut axis. So the signals from both, from gut to the brain and from brain to the gut are exaggerated actually. So they perceive a normal stimuli as abnormal, and then what they send back to through the enteric nervous system is also exaggerated response, leading to feeling of pain. We all know that stress aggravates IBS symptoms, anxiety, depression, these mood disorders or disturbances also lead to aggravated symptoms. Even in other physical condition, a patient suffering from depression or anxiety, they have lower pain thresholds. So these patients, apart from IBS, tend to have other body ache, various sites, myalgia, interstitial cystitis kind of symptoms. So IBS may be a part of a group of symptoms these patients do experience. So stress and psychological factors, they are known precipitors for IBS symptoms. Emotions significantly affect the colonic response in patients with IBS. Increased colonic functions in some patients and a decrease in others. So there is no uniform response again to stress and psychological anxiety or depression. Some patients, they do experience diarrhea, some patients they experience more bloat, some patients experience more pain in response to these factors. Both acute stressors such as deadline, exam, job interviews, or conflict with others, as well as chronic stressors such as poor financial concerns, time pressures, or family issues can aggravate the gut. This is again a well-known fact. It has even been proposed that experiences early in life may affect the CNS and confer a predisposition to a state of hypervigilance. So by this hypervigilance, they always pay more attention to even a normal GI symptom. And that's why they come back again and again to the OPD. 4 out of 5 IBS patients show psychological abnormality. So it is that high in IBS patients. Immune and inflammatory mediators, it is thought to, they are thought to play some role in IBS based on the finding that a patient who has suffered from acute GI infection in form of acute diarrhea, bacterial or viral gastroenteritis, 7 to 30% of them, after recovering from that gastroenteritis, they continue to have irregular bowel habits, mainly in form of IBSD with exaggerated pain and bloating. So this is known as post-infectious IBS. It may last up to a few weeks to even as long as 1 to 2 years after an acute episode of bacterial gastroenteritis. The risk factor of PI-IBS are female gender, duration of acute diarrheal illness, and the presence of significant life stressors occurring around the time of infection. Mucosal inflammatory cytokines may activate peripheral sensitization or hypermotility, but it is very difficult to prove in the laboratory. So again, when a patient comes to you first in the OPD with symptoms of IBS-D, it is very, very important to ask them the exact history. In my OPD, I always ask the patient that how did the symptoms start first? So did you experience that first you had 2 or 3 days of severe loose watery diarrhea with or without vomiting and a severe abdominal colic, and once that diarrhea resolved, you continue to have abnormal bowel movement. You have not recovered completely to your pre-diarrheal event. Say pre-diarrhea, you used to have 1 or 2 bowel movements. Now you are having 4 to 5 bowel movements, which is loose, but there are no alarming factors. So if you can find a specific history of 1 or 2 or 3 days of acute diarrhea, which may be because of infective gastroenteritis, you are sure that you are dealing with post-infective, you are more likely dealing with post-infective IBS. Why it is important to identify this subgroup? Because usually this subgroup responds better to therapy, and there are less chance that this subgroup comes, they subgroup have recurrent symptoms. Usually once you treat them over next 1 to 3 months or maybe 6 months, and once their symptoms completely disappear, it is very less likely that they keep coming on back again and again in your OPD, unlike other IBS patients. Serotonin, it is a part of enteric nervous system, which plays a key role in regulation of both gut motility and secretions. So involvement of neurotransmitters such as serotonin may stimulate intestinal secretion and peristalsis in addition to visceral pain. So what are 3 components of IBS? Increase or decrease secretion leading to diarrhea or constipation, increase or decrease peristalsis leading to diarrhea or constipation, and enhanced visceral pain, which is again a main part of diagnostic criteria of IBS. So serotonin is a very important neurotransmitter in enteric nervous system, which plays a key part in pathophysiology of IBS, and that's why pathway drugs which act on receptors 5-HT3 and 5-HT4, they play key role in management of IBS. Colonic transit and motility. Colonic transit is abnormal in only 10 to 20% of patients is IBS-C and 25 to 45% of patients with IBS-D. Patients with IBS-C display reduced motility, fewer high amplitude propagating contraction of the colon, and delayed transmit, which is, I think, self-explanatory. IBS-D patients have increased motility, more high amplitude propagating contractions, and accelerated transit. Influenced by alteration in serotonin metabolism with high levels reported in patients with IBS-D and low levels in IBS-C. So high serotonin leads to increased motility, low leads to decreased motility. But usually colonic transit study in form of beads and study for manometry for designification is usually not warranted in the first visit of the IBS patient. I usually reserve this study on the subsequent visits if I do feel that patient might be having some overlap of slow colonic transit or some component of designification up and above the diagnosis of IBS. So usually, say for example, if the patient is presented with IBS-C and we have started the treatment, and on subsequent visit, patient do tell you that now the stool is, previously the stool used to be very hard, but now the stool is not that hard. Patient does not have to strain too much while passing stool. Even the pain is relieved, the bloating part is better, but still he feels that the evacuation is incomplete. Then maybe we should think about designification, which subject the patient to manometry studies, not in the first visit. But some of them, they do have combined IBS with designification, and whenever there is suboptimal response to treatment of IBS-C, adding biofeedback therapy to the treatment of IBS-C, we may increase the chances of success of therapy. So patients, typical serotype, typical features of patients with IBS, and when we should subject the patient to further investigation. So usually the patients with IBS, they do come with abdominal pain and altered bowel habit, constipation or diarrhea or both. Features which are supportive to the diagnosis are pain which is relieved or worsened by bowel movements as per the ROM4 criteria, abdominal symptoms, bloating, distension, flatulence, though these are not part of the criteria, but these are usual associated symptoms with IBS. non-GI symptoms like migraine, constant lethargy, body ache, dyspareunia, interstitial cystitis. Now, maybe this interstitial cystitis is a bladder equivalent of IBS. So these patients, they do have urinary symptoms, frequency, painful micturition, burning micturition in absence of any evident UTI, in absence of any abnormality in genitourinary system. So maybe this is equivalent, IBS equivalent with urinary complaints. So these non-GI symptoms we may see in these patients may have persistent pelvic pain because of this condition. So these are associated symptoms with IBS. These presence of this plus this, they support the diagnosis of IBS. However, we should subject the patient for further investigation when any of these things are present. These are the red flags or alarming signs we must keep in mind before labeling anybody as having IBS without any investigation. Say if the age is 50 years or above, and if the symptoms, if the above symptoms have occurred recently only, previously patient did not have anything, patient is 50 years or more than 50 years of age, and there is only recent onset of symptom, at least one colonoscopy should be done. If there is blood in stool, which from history we can make sure that not because of hemorrhoid or fissure, the patient should be subjected to colonoscopy. If there is unintended weight loss, unexplained anemia, there is familiar history of IBD, patient comes from the part of the country where celiac disease prevalence is very high, or there is any family history of colon cancer, family history of celiac disease, any obvious abdominal mass on physical examination, any presence of ascites, elevated WBC count, loss of appetite. This symptom standalone may or may not be pointing towards any organic cause, but loss of appetite along with anemia, along with weight loss, which is unintended, may be indicative of some organic cause. Nocturnal symptoms, again, this is very, very important. Any bowel movement which awakens the patient from the sleep. Patient is sleeping and has to go to the loo from the sleep. Must not be because of IBS. We must evaluate the patient for other organic causes. Presence of persistent low-grade fever and any recent change in symptom. Patient is a known case of IBS, but recently there is some change in symptom and some additional alarming sign. Then this patient should be subjected to further evaluation. So what are the routine investigation? All patients in whom we feel this is IBS, they should have complete blood count and CRP and or fecal calprotectin, depending on the patient's history and family history and our clinical acumen. But these are the baseline investigation which must be done in all IBS patients. Now, specialized investigation in patients who belong to area with high celiac disease prevalence. At least serological test should be done to rule out celiac disease. If positive, patient should be subjected to endoscopy and biopsy. Any recent visit to tropics, this is of course for foreigners. We are always, subjected to recurrent GI infections, especially any visit to outside, any contact with outside food, any recent tour. This patient, we must rule out infective enteritis or enterocolitis by doing stool test. And there is no response to any of the therapy, then we should subject the patient to this test to rule out any associated condition. There is strong family history of colon cancer, unintended weight loss, rectal bleeding, which is not local, and abdominal mass. Colonoscopy, age more than 50 years, should always be subjected to colonoscopy. How to manage IBS? So before management, we should look for severity. Why this helps? Because these are some scores which may give us an objective idea how the patient is improving. Because most of the times we depend on the subjective feedback. On follow-up visit, we just ask the patient how he or she is feeling. But what happens is, most of the times it is human tendency that the patient pays more attention to the persistent symptoms. Say the patient presented in the first visit with increased frequency, diarrhea and pain. Now the frequency is still somewhat improved, but the pain and bloating part is much more improved. The moment patient enters the OPD, the patient will report that there is hardly any difference. Then we have to dig deep to ask, then gradually the patient will tell, no, only diarrhea part is there, but the pain is better, the bloating is better. Instead, if we have a fixed questionnaire in our OPD, so on first visit, we ask the patient to fill that questionnaire. On subsequent visit, we ask the patient to fill the same questionnaire. So we have a definite score which give us and the patient a definite idea that the patient is improving, and that will give more confidence to the treating person as well as the patient. So this is the example of the scores, very simple and quickly, the questionnaires are very simple, very few, and can be quickly filled by the patients, and even the calculation is very easy. So even this gives, if there is any reduction of 50 points in the subsequent visit, it means the patient is improving and we should stick to the therapy. So in general, while managing the patient, first we should identify what is the predominant symptom. What is the symptom which harasses the patient the most? Also, you must consider the previous therapies. As I said, usually patients are there with multiple files and must have received multiple treatments in the past, with or without improvement. So we must go through this treatment. So rather than avoiding the same treatment again and again, we may find out that what was the problem with previous therapies, and we may modify the treatment accordingly. Then educate and reassure the patient. I feel this is the most important part. Most of them, we are not paying enough attention. We are not giving enough time to the patient in counseling. Most of the patients, they do believe that because they are suffering from so many years, because they have visited so many doctors and there is hardly any relief, whatever the underlying condition is, that is very, very severe and which may be life-threatening. Most of them, they do have the fear that they are having cancer. So education and reassurance is the most important part in treating such patients. It builds the rapport also. It gives patient more confidence in you. And if psychologically, if patient is having more confidence in you, the chances of success in treating these patients is very, very high. So tell them that this condition is not life-threatening. They are not having cancer. Whatever it is not going to lead to any other life-threatening illnesses. At max, if the therapy doesn't work, or if any of the doctors in the city is not, able to relieve their symptoms, all they are going to live with is the symptoms and not any other major illness. So whatever life they are living right now, the quality is going to remain the same. They are not going to bed bound. They are not going to undergo any major surgery, or the lifespan is not going to be reduced because of this condition. After doing this, only you start optimizing the treatment. First and foremost, of course, is non-pharmacological therapies. After that comes the role of the pharmacological therapies. Usually, with the patient, when the patient reaches a gastroenterologist, the non-pharmacological therapies have already been tried. You just need to ask them that what kind of non-pharmacological therapy in form of dietary modification they have already tried, based upon the feedbacks from their primary treating physician and based on the feedbacks of the Google. And you just need to modify those things. And simultaneously, you must need to start the pharmacological therapy as well. So for specific therapy, different guidelines, they do include different drugs at first line, second line, all those things. But ultimately, it's our clinical acumen and our experience which matters the most. So for IBS-D, loperamide, which is available here, rifaximin, which is available here. This is British guidelines, so they don't have ramosetron and all those things, but we do have ramosetron also as a part of therapy of IBS-D. Loperamide has been shown to reduce the frequency of diarrhea. There are some known side effects which I'm sure you all are aware. But whatever studies have been done on loperamide in IBS-D, though the diarrheal part is improved, the stool has become formed, the frequency has reduced, but still the patient of IBS-D are not satisfied with that. So it shows that it's not only diarrhea in IBS-D troubles the patient. It fails to relieve bloating, it fails to relieve the pain, and overall feeling of well-being is not there with loperamide. But still, whenever the frequency is the most troublesome feature, loperamide can be tried. it should be started with lowest possible dose and the dose should be titrated upwards based on the effect and side effect part. Ondansetron is a good alternative to remocetron. The dose can be titrated upwards till 8 milligram TID. Rifaximin, short course of rifaximin 550 milligram thrice a day for 14 days is found to be useful in reducing bloating and in reducing the frequency of diarrhea. However, recurrence is bound to happen, and maybe these patients require repeated treatments every 2 to 3 months. Repeated treatment up to 2 or 3 times is recommended. After that, you may need to switch to other treatments. Probiotics, though there are so many probiotics available, but the role is, the recommendation, they do say that it may be tried based on the patient's preference, may or may not be helpful, but most of the times it is not harmful, apart from in patients, immunocompromised patients, in which it may lead to a heightened risk of sepsis. It may be tried, but if tried, that should be continued at least for 12 weeks to see if there is any benefit or not. Antispasmodic, they are used when the pain is also there along with diarrheal symptoms, and it is one of the predominant symptoms. Tricyclic antidepressant, they usually have good effect on global well-being. Overall, all the symptoms they do relieve, they do have some effects. If we talk about constipation, water-soluble fibers they form the first-line therapy. Isabgol-based fibers or diet which contains water-soluble fibers like fresh fruit, fresh vegetables. Water-insoluble fibers like wheat brains, nuts should be avoided because they worsen the symptoms of bloating. Even water-soluble fiber, they should be started with low dose of around 4 to 5 gram per day, and those should be titrated upwards up to 20 to 30 gram per day. And we must educate the patient to take sufficient water along with that. Lubiprostone is available. Laxatives like PEG, lactulose, lactitol, they can be used. Lactulose and lactulose have a good effect on relieving constipation, but they again have aggravating effect on bloating part. Lubiprostone have good again it's a good drug, selective chloride channel activator, which secretes the water into the intestinal lumen and which leads to waterification of the stool, so constipation part is relieved. Prokinetics can also be used. Pain part, again, antispasmodics, SSRI. So the one side effect of TCA is constipation. So TCA are more useful in patients with IBS-D, while one side effect of SSRI is diarrhea. So they are more useful in IBS-C. Mixed type of IBS and IBS-U are always, very difficult to treat because of maybe alternating diarrhea and constipation, or maybe the predominant pain symptoms. So we have to use the laxative. We may stop loperamide depending on whichever symptom is predominant at the particular point of time. So basically, these patients are difficult to treat group. The treatment needs to be changed every 1 to 3 or 6 months based on the predominant symptoms. And at the end of that, again, these patients are the least satisfied patients. So this is the BSD guideline algorithm. We'll also go through what Indian scenario is. So first and foremost, explain the patient what actually IBS is, and and also discuss simple lifestyle and dietary advice like regular exercise, reducing stressors, some yoga, some meditation for better mental well-being, for better handling of stressors in life, and some dietary advice. If patient is able to accept his condition as harmless and is relatively stable and relatively symptom free with this non-pharmacological symptom, that should be it. We need not to be in hurry to start the treatment. But if, as we have seen in most of the patients, patient is not happy with only this, we need to start some treatment of them. Then comes the role of subclassification. So in IBS-C patients, laxatives, as I already told, they do improve the constipation part, but they still do not improve the IBS part much. The same holds true for secretagogues and 5-HT4 agonist also. They do take care of the constipation part, but for IBS part, we usually need to add some TCA or some other antispasmodic agent most of the times. In patients with IBS, loperamide can be used. 5-HT3 receptor antagonist like remocetron or ondansetron can also be used. If we also suspect rifaximin can also be used, especially when we suspect some component of SIBO as well. Difficult to treat patient is IBS M and U. Usually antispasmodic is the first line because they have pain as the predominant symptom, along with antipsychotic medications. But most of them, they do end up with hypnotherapy and brain treatment, cognitive brain therapy. So these are the recommendations from Dr. Uday Gosal sir in Indian scenario. We have seen he recommends in case of constipation, first line therapy should be soluble fiber, laxative like polyethylene glycol, lactulose, lactitol, and stool softener. But as I already said, most of them, they do relieve constipation, but they do not relieve other symptoms like pain and bloating. Then if these agents, they do not, they do not succeed, we may add or we may switch to the second line agents like sodium picosulfate, lubiprostone, or procalopride. This is the future, not available right now. For patients with diarrhea, loperamide is the first line drug, which takes care of the frequency part and stool consistency part, but does not take care of the pain and bloating part. We may add or we may replace this agent if it doesn't work with remocetron or ondansetron. Bile acid sequestrant, again, this is a controversial thing to use. In patients with history of cholecystectomy and diarrhea after cholecystectomy, and in patients who are having otherwise symptoms of IBS, all other criteria are fulfilled, but the patient is having nocturnal diarrhea, and we have fairly ruled out other organic causes. In these patients, we should think of bile acid diarrhea, and we may give them a trial of bile acid sequestrants, but these are, again, very poorly tolerated agent by the patients and very difficult to use as well. Frankly speaking, I have rarely used them in my OPD. Rifaximin, we have already discussed. Clonidine can be useful in patients with diabetes when we suspect some overlap between IBS and diabetic diarrhea. For bloating part in patients with constipation, of course, treating constipation does help. We may use probiotics, we may use rifaximin for bloating, but again, this is very difficult to treat symptom in IBS patients. Pain, we can use antispasmodics, which are anticholinergic agents, antimuscarinic, and calcium channel blockers. These are all good in relieving pain. We may use tricyclic antidepressants and SSRIs as an add-on therapy, second line therapy. Again, this is an American algorithm, more or less similar, but just to show you that the problem is almost there across the entire world, and everybody, they do recommend mix and match of various drugs rather than sticking to any single molecule and any subtype of the IBS. So exercise, of course, overall symptom improvement is then. In fact, exercise have good impact on overall sense of well-being. So even if the patient is having some symptom of anxiety, depression, these symptoms also respond well to exercise apart from GI symptoms. In GI symptoms, constipation improves better than diarrheal part whenever exercise is introduced in the life. Dietary manipulation, low FODMAP diet. Again, low FODMAP diet is something which is very difficult to implement because dietary restrictions are too much. Patient requires the help of dietitian, professional dietitian, to implement this low FODMAP diet. But in those patients who are having persistent symptoms, especially of bloating and diarrhea, low FODMAP diet can be tried, and if found successful, should be continued at least for 2 to 3 months. After that, gradually, one after another, food component should be introduced in low FODMAP diet. And when the patient shows any recurrence of symptoms with re-challenge, that particular food component should be avoided, and rest of the food component should be reintroduced gradually and should be continued. Gluten-free diet, 2 studies have been done, but we have not. It was not found to be effective. And IgG antibody test based exclusion of diet is also not recommended, because it was found that in 80% of the patients, some or the other food component showed positive antibody, but removing this food component from the diet did not show any major change in quality of life and symptom. And reintroduction of this food component or re-challenge with this food component also did not show any major worsening of the symptoms. So IgG based exclusion diet is not advisable. So these are the low FODMAP diets. What are the FODMAPs? They are basically short carbohydrate containing food items. So these are fermentable food components. So they cannot be digested by GI tract. So that's why they are fermented by the GI flora. And because of this fermentation, they produce excessive gas, excessive hydrogen, excessive methane, which may lead to excessive bloating and pain. They also kind of hold more water inside the lumen, so which may lead to diarrhea to the patient, diarrhea in the patient. So whichever diet, the diet which contains this high FODMAP, highly fermentable oligo-di-monosaccharide and polyols, they should be avoided from the diet, and diet containing low FODMAP should be introduced to the patient. How probiotic helps in IBS? So they help mainly in 3 ways. Can protect against pathogenic bacteria via antimicrobial properties. They do amplify intestinal tight junction and stimulate goblet cell to produce glucose to enhance intestinal barrier function. Various probiotics in single and in group have been tried, and various studies are available, but most of them, they do report some improvement in symptoms, but recommendations, they do vary. If introduced, they should be continued for long enough duration of 2 to 3 months at least. Antidiarrheal, we have already discussed. Loperamide effective in diarrhea, but not in other symptoms. Antispasmodic may be effective for global symptom and abdominal pain, but especially in elderly, dry mouth, visual disturbance, and dizziness are common. These are various antispasmodic studied in with various compared through various studies. You can see the number needed to treat with most of them are across from 2 to 5. Mebeverine, which we use so frequently in our day-to-day life, surprisingly, it was not found to be useful to make significant difference in pain. As you can see, the 95% confidence interval from 0.93 to 1.5. So as far the recommendations are there, it was not recommended. However, from our clinical experience, we do see that it is a useful molecule. Tricyclic antidepressant, we have already discussed in patients with anxiety and depression, along with symptoms of diarrhea. It may be more useful. It takes care of global symptoms, reduces almost all components of irritable bowel syndrome. Should be started from low dose and titrated to the maximum tolerated dose. SSRI, more useful in IBS-C part, again takes care of global symptoms of IBS-C. 5-HT3 antagonist, rebosetron, ellocetron. Ellocetron is not available. It was introduced and then withdrawn in between because of high risk of systemic colitis. Again, have been reintroduced at a lower dose, but it is not available here. Remosetron is a relatively safe drug, available freely in the country. And it has got good response in IBS-D patients. It reduces pain as well as it reduces diarrheal frequency. So it is a relatively safe drug, easily available. And I would say it should be included in a patient with IBS-D. So this is the meta-analysis. It also shows favorable response in all IBS symptoms overall, IBS discomfort and pain, increased frequency, and stool consistency. So basically, it has shown favorable response across the spectrum of IBS-D. It is a good molecule. Antibiotic, rifaximin, we have already discussed, should be given 550 milligram TID for 2 weeks, and the course should be repeated 1 to 2 months if required, maybe maximum up to 2 to 3 times. Tegaserod is not available. Procalopride is available. So it, as I already said, it reduces the constipation part, but does not reduce the IBS part much. So we need to add some antispasmodic and some tricyclic antidepressant, SSRI along with that. In miscellaneous part, peppermint oil, it is available by 1 or 2 companies in India as well, I think. It reduces gastric motility by directly acting on gut lumen, gut calcium channel to relax GI smooth muscles, mainly useful in relieving part. Should not be used for more than 12 weeks. The dose is 0.2 to 0.4 ml TID or 180 to 225 milligram TID. The main side effect is GERD, heartburn. Melatonin is again available. It has analgesic effect, helps in alleviating abdominal pain and influences the sensation of abdominal distension. So mainly helps in bloating and pain part. It acts on melatonin receptor, needs to be taken at bedtime. In long term, it may lead to depression. So that is the thing which needs to be kept in mind, because most of these patients, they are already suffering from depression. Adding melatonin may aggravate their symptoms. Psychological therapy is very neglected part. Usually, frankly speaking, not available in major part of the countries because of lack of interest. And most of us and most of the psychiatrists, they are also more inclined towards pharmacotherapies rather than cognitive behavior therapy or hypnotherapy, but should be good for patients who respond poorly to pharmacotherapy and should be offered if available locally. So follow-ups should be done at 4 to 8 weeks. And again, each and every component of the IBS should be assessed, and we must look into each and every component, which part is better, which part is still not better, whether patient has experienced any adverse reaction or any side effect to the drug. The drug should be changed according to the component which is not being improved, and the component which is better, the drug should be continued. Some of the patients, they do require prolonged therapy with TCI and SSRI, maybe till 6 or 12 months as well. So to summarize, there are no diagnostic tests to diagnose IBS basically, but previously it used to be the diagnosis of exclusion, that when you want to diagnose IBS, you exclude all other diseases by doing a battery of tests, and when all the tests are negative, you diagnose that patient as having IBS. Now that approach is gone. Now it is confident positive diagnosis is more important rather than diagnosis of exclusion. You don't subject patient to battery of tests. You just do baseline test, use low clinical acumen, use ROM4 criteria, and make positive diagnosis of IBS. You subject the patient to further investigations only in presence of red flags or alarming signs. Subclassification is very important along with diagnosis and treatment, because treatment is useful and successful only if we subclassify the patient. Lifestyle, dietary management, removal of stressor forms the mainstay along with pharmacotherapy. No single pill fits the bill. You have to individualize the approach. If everything fails, psychotherapy. But still, I would say there is a long way to go, because most of the clinicians, most of the researchers, still they are not interested much in IBS, even though these patients form the major chunk of our OPD and major chunk of our income also, I should say. Thank you.
So thank you so much, sir. It's a wonderful discussion about IBS. You have made a very comprehensive discussion on the IBS. We have few questions in the chat box. I would like to request the audience to put the question again and again. Right, so you can answer those questions. We have an interaction between the speaker and you, right? Or even you can also unmute yourself and ask the question to our speaker. Right. So first question, sir, I just take, is there coexistence of IBS C and D?
So basically IBS C and D is what we know as IBS M, or mixed component of IBS. So these patients, they do have on some days of the week and months, they do have solid constipated stool, and on other days of the week, they do have diarrheal type of stool. So that is what we identify as IBS M.
So thank you, Dr. Patel, for asking the question. And now I move to the another question that Dr. G. Kishore, I think so, he has asked. Ramosetron long-term safety with comorbid patients. He is asking that any comorbid patient you have used.
Yeah. So ramosetron should be used a bit cautiously in elderly patients, in those with, having history of already some ischemic cardiac or brain disorders. But overall, it is a much more safer molecule than alosetron. And ischemic colitis incidence is not there as we used to see with alosetron. So relatively safe drug, except in elderly group of patients.
So I'm just waiting for other question to come. Sir, actually in your discussion, you told very nice things about that you measure the severity scale of a patient. So sir, could you elaborate these things? I think so that is the first in a discussion of any IBS Gurukul that we got that aspect also. Right. So could you sir give a little bit more elaboration on that how you define that IBS severity scale and how you understand that, sir, how the patient is improving on
So IBS pain you are asking, no? Pain in IBS.
severity scale. You told that the IBS severity scale, few questionnaires you have.
Yeah, that is good. That is good. So IBS severity score usually it's a very less used tool in our day-to-day OPD. But what I suggest is, see, if you are interested in IBS and if you are intending to start a special IBS clinic on a single on some days of your week, it is always better to use these batteries. These are easily available online. You can Google it and you can get the questionnaire. You can choose whatever questionnaire you feel comfortable with. But one I showed which had a specific scoring system and which also showed that any improvement or any reduction in score by 50, it means that the therapy is working. So why it is useful is you can allot a staff for this questionnaire. A patient comes to you first in your OPD and you ask the staff to fill the questionnaire and get the score. You can write the score. You can modify the treatment, and on follow-up visit, if you can demonstrate to the patient that, see, on first visit your score was 330 and now on this visit your score is 200. So there is improvement of 130 in the same score. So even if you are having some symptoms, you are still not completely better. You are still not completely satisfied.
Exactly.
At least we are moving in the right direction. So that much confidence, if even if the patient gains that much confidence, the patient will stick to you. Number one. Number two, the patient psychology will improve. Till now, whatever he has experienced is there is no improvement. There is no improvement. Whatever he has tried, he has not improved. Now you are proving to him that he is improving. So that will boost his confidence. That will reduce his anxiety and stress, which again will, make your therapy more successful.
Exactly. For this reason, I asked this question because it seems very interesting to me because that IBS management is a symptomatic management. So at a go, all the symptoms could not be managed because the
So
therapy
till
will
now, we used to have this score in organic diseases like IBD, inflammatory bowel disease. These score are, very well defined and usually used by most of the gastroenterologists regularly.
Okay.
But now this is for the first time that even in IBS, this score is there which can be used. But most of us are not aware. That's why we are not using it.
Yes, yes. So is a American family physicians kind of a tool? This is taken from where? So the IBS severity
Yeah.
scores.
So some British scores are also there and some American scores are also there. So I have mentioned 5, but there are more than that.
More than that.
Yeah.
Okay, right. Okay. So, audience, could you post your question here? Sir, how common? Because I just wait for the few more questions to come. So, sir, how common that blotting and because see, that's a you told in Rome 4 there is a there is a more abdominal pain as pain will be more means there's a emphasizing more abdominal pain. But how common this blotting and distension in Indian patients?
Bloating is very common, I should say, especially in IBS-C patients. Most of them, they are having bloating, which is not that common with IBS-D part.
Okay.
But bloating, again, is kind of a subjective feeling.
Okay.
And there is no specific definition for bloating. So that's why it is not included in the diagnostic criteria because diagnostic criteria are for research. But almost, I should say, 70 to 80% of the IBS-C patients, they also complain of bloating. Okay. And they categorically say that on days when the stool, they are not able to pass the stool successfully, on those days, the bloating is more. And on those days when their bowel movement is okay, the bloating is less.
But sir, even that's you say that's a constipation patient there, the bloating is very common, right? Now, what I've seen that's in the Dr. Uday Ghoshal that what he has written down about that how to manage IBS. So the therapy are two. One is a probiotic and another is an antibiotic. So it is a perception that majorly the probiotic to be prescribed in the diarrhea cases, not that constipation.
Yeah, because most of us have seen that diarrheal cases, they do have some component of SIBO, small intestinal bacterial overgrowth. And that SIBO may give rise to bloating as well.
Yes.
because
yes.
ultimately bacterial overgrowth leads to more generation of hydrogen and methane, and which leads to bloating.
Bacteria.
So
Correct,
whenever in
exactly.
diarrheal patient, of course, bloating is there, probiotic and rifaximin should be added to the existing therapy.
Sir, I mean to say that's if you say that's a diagnosis, because you say there's a very critical patients are coming, there is a problem to make them to stick on that therapy. So if you entire presentation, in your entire presentation, if you say the one take home message for that physician, that how to that manage this IBS patient, how to reassure them that the therapy they are prescribing, it will be working for them, because the patient is a little bit in doubt that is it working
Yes,
for me.
agree. So first thing I think that we all as a treating physician should do is take IBS seriously. General notion in clinician, in gastroenterologist, the moment they stamp the patient as having IBS, or they see the file that someone has already stamped the patient as having IBS,
Mhm.
they just take the patient as a psychiatric patient. Even after knowing all these things, most of us still have that false belief that this patient is only having a psychiatric problem, and that's why he is having this GI condition.
Okay.
But as the research goes on, now we know that it is not only the mental well-being or mental disease which is causing this thing. There is something going on inside the GI tract as well, which is causing the symptoms. Though we are not able to pinpoint exactly what is going on, but something is wrong. So first and
Correct.
foremost, we must be serious about this patient. Then build a very, very good rapport. Educate the patient. Okay? Don't give him false hope. They go, no, I'll give you medicine and everything will be all right. That is never going to happen.
Correct.
Tell them
Correct.
that this is a long journey. We'll have to get along well and we'll have to go hand in hand. I'll be able to reduce some of your symptom. I'll be able to improve your quality of life a bit, but I may not be able to relieve all your symptoms.
Yes.
But this is the only solution we have as of now. Be honest with them.
Correct.
Chances are high that they will stick with you.
Sir, you told about the criteria, like Rome 3, Rome 4 criteria. I heard that most of the gastroenterologists in India follow the Manning criteria. Is it correct, sir, that they follow the Manning criteria? They think that Manning criteria is more relevant in the diagnosis of IBS.
Yeah. So as I already discussed in my first slide as well, most of the gastroenterologists, they use their clinical acumen actually,
Okay.
even not even Manning criteria.
Okay.
That a patient who looks fairly all right, basic reports have already been done outside somewhere and they are normal. There are no physical findings, age and other symptoms, pain, altered bowel habits, they are fitting into IBS broadly. So most of us, we don't go into minute detail. Okay, are you having symptom once a week?
Okay.
Are you having symptoms
I
since last 6
understand. I
months?
understand.
It doesn't make any sense. I mean,
Yes.
it is useful when you are going to publish a research, because why it was developed? Because before Rome criteria, the different paper used different criteria for diagnosis of IBS. Now, when guidelines were being made for therapy and for treatment of these patients, there was so much confusion, because one study used this criteria and showed that this drug was useful. Another study used another criteria and showed that this drug is not useful. So it was, they thought that there has to be some uniform criteria. Whenever the research is being done, one must use those criteria. And that is the main purpose of, forming the criteria rather than the clinical use.
Very nice, sir. Very nice discussion. Means we had a very good discussion. We have a almost 50 audience. So, sir, I'd like to come to the close the session with that closing remarks. Before that, any doctor could ask any question. I just wait for the 1 minute that if I get any questions from the doctor. But it's a very wonderful thing, sir. This IBS awareness month, you discuss about the IBS, because as I remember that IBS awareness is very poor among the patient. Only 20% of the IBS patient will seek medical care, and from there only 50% is 10% of the 20 is coming to the gastroenterologist. So we are also trying as a company that to increase the IBS awareness in this IBS awareness month, and to continue as increasing the IBS, because the prevalence is very high in the India. And you may also agree that change of food habit and the sedentary lifestyle may contribute stress, may contribute the increase of IBS in India, right? So any question from audience? So I'm not getting any question right now. Any question you would like to ask Dr. Avval? Audience, any question you would like to ask to Dr. Avval? Yeah, you can post or you can also unmute yourself and speak. Yeah. Okay. So we'll be going for the closing. Sandeep, are you ready for the closing?
Yes, sir.
Yeah.
Yes, sir.
So could I share
Yeah.
my slides? Yeah. Just hold on. I'll just share my slide. Yes. Yes,
Yeah.
Sandeep.
Yes, sir. So, good evening, all. On behalf of Zydus, I, Sandeep Gedam, would like to thank all of you for your active participation. I would really like to thank Dr. Avval Sadikot for his wonderful presentation and taking out the time. This IBS Gurukul is on IBS diagnosis and management, and it was indeed our privilege to listen to you, sir. Last but not the least, my thanks to the entire participating clinicians, without whom the event would not have been possible. It goes without saying that we will continue to rely on your affection and support now and thereafter. Thank you, everyone, and good night, and have a wonderful weekend. Thank you very much.
Thank you.
Thank
Thank
you,
you.
sir.
Good night. Good night.
Yes.
Indeed, sir. Sir, indeed, sir. The session is very nice, very nice, very
Thank you.
informative, and
Thank you.
and you are the gold medalist. You have proven in your sessions.
Thank you. Thank you, sir. So
Very
nice.
nice, very nice.
Thank
Really,
you.
I have enjoyed because I have